Hello and welcome. My name is Jamie Gillespie and I want to talk to you today about Telestroke in rural emergency departments and how it revolutionized my nursing practice. On the agenda is a brief introduction about stroke and stroke care in emergency departments, the purpose of Telestroke, setting used, and an in-depth analysis on Telestroke and integration of the scope and standards of practice according to the American Nurses Association. First off, what is a stroke? A stroke is when a blood vessel in the brain is either blocked off by a clot or it ruptures and bleeds, and then it impairs oxygen delivery to that brain tissue. The neurologic deficits that we see depend on the area of the brain that's affected by the ischemia. Each second that passes, about 2 million neurons become damaged and die, which results in progression and permanence of the damage. So that makes rapid treatment imperative. With an ischemic stroke or a clot, we give thrombolytics such as TPA or now tenecteplase within about 4.5 hours of symptom onset. This is because the risk of hemorrhage with the blood with a thrombolytic outweighs the benefits of treating the stroke, as the more time that passes, the more likely the damage is irreversible. There are some rare situations where tenecteplase can be given up to 24 hours, but the outcomes are not very statistically significant. We rate our severity of a stroke based on the NIH stroke scale. Here's just like a brief grading scale. 0 to 42. The higher the number, the worse the stroke is, and the more likely the patient can benefit. For example, if your stroke scale is 3, and maybe you can live with this, perhaps the side effects or the risk of giving a thrombolytic might not be of benefit. But of course, the more debilitating the stroke, the more likely you are to benefit, and the benefits would outweigh the risk of the treatment. And what is Telestroke? Telestroke is the use of telecommunications to provide specialty consultation to stroke victims in the emergency department. The providers, neurologists, neurosurgeons, neurovascular, interventional radiologists, they can remotely see and communicate with the patients and caregivers. They can perform the neurologic exam remotely, receive and transmit imaging in labs, and they can advise the in-person staff on the trajectory of care and need for transfer. There are several different hierarchies or levels of stroke centers. Comprehensive stroke centers are the most comprehensive. They have 24-hour care, the best imaging, and they do the most procedures. Rural or critical access hospitals do not staff neurologists. They really don't have the resources to take care of these stroke patients. So the setting that we're using Telestroke in are these rural emergency departments. The literature shows that rural emergency departments, they have less thrombolytic use, and when they do use it, the time from symptom to treatment is much longer, which leads to worse outcomes, of course, because of the time sensitiveness, because time is brain. The purpose of using Telestroke in these rural emergency departments is ultimately to decrease the time from the onset of symptoms to the time of treatment. The door to needle time is what we also call it. There was a meta-analysis in 2020 that does show that Telestroke use in the emergency department significantly increases the likelihood that patients receive thrombolytic therapy within a window and end up with better neurologic outcomes, lower mortality, less disability. Telestroke can almost instantly provide these rural emergency departments with comprehensive stroke centers that do have the best of the best advising the care. So the time of treatment can truly be the difference between a patient having a full recovery and have long-term disability. Myself, working in a rural emergency department earlier in my career, I unfortunately have seen patients with stroke symptoms come in. We get them to the CT scanner, and we know they're having a stroke. and we are waiting for neurology consultation, or the patient might be complex or be on a blood thinner, so the provider isn't comfortable, so we're waiting for that expert consultation. And sometimes hours can go by, and then by the time we hear back, the patient is outside of that window and can't get treatment. And it is very sad and very unfortunate that just because of your geographical location, that you're not going to receive care and end up with that just permanent disability because of it. And more recent literature does show that the diagnostic accuracy of telestroke compared to in-person neurology is comparable. Telestroke increases thrombolytic use by 73% and does not result in an increase of hemorrhagic complications. And it also increases the actual use of thrombolytics within that 3-hour window by almost twofold. Higher functional outcomes and lower mortality, which is the ultimate goal. And I truly have seen that in practice, and it is amazing to see the difference of a patient that comes in, you get them to CT, work up the telestroke, and they can see that neurologist and get treatment within minutes instead of hours. Absolutely revolutionizing. So where does nursing informatics come into play in here? As our nursing informatics leader, manager, and other co-workers, of course, our scope of practice is that we take data to information, to knowledge, to wisdom. Data is what we get for our direct care. We process it into information to actually give that data meaning. We use knowledge to interpret and understand the information, and then we use knowledge into wisdom to actually solve the problems that we have. Our scope of practice is that we are using computer science, nursing science to deliver, improve healthcare, deliver the best care, safety, quality, and best patient outcomes we can. So the question is, does utilization of telestroke in rural emergency departments within 4.5 windows of stroke symptoms lead to improved patient outcomes? And the research and evidence base does say yes, it does. The American Nurses Association also gives us 16 standards of practice in nursing informatics. First is assessment. We're collecting the data, diagnosis, analyzing the problem, identifying our outcomes. What goals do we want? Our goal is that we want more stroke patients to receive the appropriate therapy in the appropriate amount of time, leading to better outcomes. Planning. How are we going to attain this outcome? Implementation, coordinating activities, teaching, promotion, and consultation with our end users and people that are going to be using this, making sure people know how to use it, when to use it, troubleshooting, know who to call. And evaluation. Are we progressing towards our outcomes? Are patients getting treatment sooner? Are they getting treatment when they normally or previously wouldn't? Are patients getting better outcomes? Shorter length of stay, less disability, less death, less complications. And of course, practicing ethically with our patients' best interest in mind. Using education, our knowledge and competency. Evidence-based practice, using our research into practice. Providing quality and effectiveness of care. Communicating effectively within all areas. Showing leadership in your department. Collaborating with providers. It is really huge. There has to be a lot of trust when you're working remotely with other providers. Those neurologists or neurosurgeons, they really depend on our bedside assessment to make sure things are being properly done. Making sure professional practice is within standard and guidelines. Research utilization, making sure we're not overusing or wasting resources, and making sure the resources that we have go where they need appropriately, so everything runs smoothly, and always keeping safe and healthy environment in mind. So in summary, utilization of Telestroke in my rural emergency department has revolutionized my practice. Delays in receiving thrombolytics, procedures, and transfer are now almost completely eliminated due to this rapid availability of specialty consultation remotely. My patients are now receiving the best care possible very quickly, and they have the best chance for a full recovery. Thank you for listening. Any questions?